if we go to bacterial infections straight away, right? What are the common infections? Impetigo, cellulitis, and SSSS, right? Now, this patient, right? This patient, if you get this picture in MRCPCH theory paper as a photo, or if this patient comes for MRCPCH, one of the miscellaneous stations in the clinical exam, or if this picture or a short video comes as a video station in MRCPCH clinicals, right? How would you approach? Now, every time when we see something related to MRCPCH, we have to train our brain. How can this come as a theory question? How can this come as a clinical question? Then it is very easy, right? So how do you describe this? Now, this is called impetigo, right? This is called impetigo. The typical description is a honey color crusted lesions. If you are to write an answer in MRCPCH clinical, or if you are to say, tell me what you have just seen in your video station, you can say, I have seen a 4 years old, otherwise well child with honey color crusted lesions around the nose, just above the upper lip, right? So that is something that you would say. Then the examiner will ask, okay, now you have described about the lesion. Tell me what is the likely diagnosis, right? What is the likely diagnosis? Then you would say this is likely to be impetigo, right? Impetigo. Now, when somebody asks what is the likely diagnosis, don't try to elaborate things. Try to be short and precise, because we are not going to achieve a lot by giving a long answer when the answer expected is short. So you would say impetigo, right? Impetigo. And then they might ask what are the different kinds of impetigo that you know of, bullous and non-bullous. Keep it simple, right? Bullous impetigo and then non-bullous impetigo. So those are the two types of impetigo. Here you see there is no bulle, it is flat, right? So this is what? A non-bullous type impetigo, right? Non-bullous type impetigo. Now, non-bullous is commoner, right? Non-bullous is commoner. How are they triggered? How do children get impetigo? This is due to a bacterial infection. However, this could be triggered by some insect bites. Could be due to minor abrasions, ABs, right? So they could be the initiating point, and then on top of that, you get a bacterial infection, right? So the typical description is that child will get a honey color crusted plaques, honey color crusted plaques. And then they would spread from one part to the other part. Suppose the child is rubbing his nose a little, then what happens? Everything will touch on the hand, and then he touches one of the other parts of his body, say the thigh. Then the thigh area also get the same infection. This is called auto-inoculation. Same person will spread the lesion from one area to the other area. And say, then this 4-year-old child goes and touches his sister, 2 years old, then she also will get it, right? She also will get it. So proper hand hygiene is very important, right? This can come as a patient education scenario in communication station, right? Patient education scenario in communication station. So then the actor will ask, actresses or actor will ask, doctor, could you please tell me how to prevent this spreading to my other children? Then you need to say what kind of preventive measures that you would take, right? So may spread to other parts of the body, right? And then occasionally this could be itchy, right? It could be itchy or it might not be itchy. And then the other type is non-bullous, bullous impetigo. You see bulle, right? They are fluid filled ones. Some of them are very flaccid, right? Very flaccid. still this is impetigo, right? Still this is impetigo. Those are common around the face, buttock, trunk, and perineal area, right? Can it occur in newborn babies? Yes, this is called neonatal bullous impetigo. So neonates also can get this, right? So it's important to know that this could occur in any child, right? This is the other question that examiner would ask. How would you treat? How would you treat? So we need to know how to detect impetigo and confirm that it is impetigo, and then that it is a bacterial infection, streptococci or staphylococci. Then we need to know how to treat. How to treat. So the treatment options, right? You can give topical mupirocin, right? Topical mupirocin can be given, and then systemic oral antibiotics can be given. Oral antibiotics can be given. One of the commonest antibiotics that we give in the United Kingdom is flucloxacillin, right? We can give flucloxacillin. Sometimes you also can give coamoxiclav, right? Coamoxiclav, flucloxacillin can be given, and cephalexin is also good enough, right? Cephalexin is also good enough. And you would take a skin or the fluid swab, and the swab will be sent to the microbiology. And then microbiologist calls you and says that in that swab, you have MRSA, right? Methicillin resistant Staphylococcus aureus is growing. In that case, you might give clindamycin, right? You might give clindamycin. So this is something that we need to know, right? So impetigo, we know when you see this kind of picture, okay, this is impetigo, honey color crusted lesion. Then this again is impetigo. This is the type of impetigo called bullous impetigo. And then it is both of them are staphylococcal or streptococcal infections. The treatment is either topical mupirocin, or you can go for oral antibiotics, right? So if we know, and then the hand hygiene is very important. This can spread from one person to the other person. It's a good idea until the complete lesions are crusted and healed, not to send these children to school, right? Not to send these children to school, right? So that's the part. So this can come as a single best answer question, or this could be a video station. This could be a patient education scenario, right? Sometimes, very rarely, this could be given uh, uh, as a like telephone conversation, right? You are telling the mother that your child's sub is positive for MRSA, right? You need to discuss, you need to describe, this is what we have found, what is our treatment going to be. In that case, you might say your child will need a separate treatment called clindamycin, right? You might give clindamycin orally. So please go to your general practitioner, GP, and get clindamycin prescribed. We are going to send a letter to him. So by the time you go there, he will have the letter. So they are, your GP is aware that you are coming. So please go, right? So that kind of information will be needed to be communicated if the scenario is like that, right? So this is one of the skin infections which we have to know very well, right? So what do you say this one, right? Now, if you see a child like this, yeah. Any comments? Yeah. What do you see here? Now you see his left lower limb is edematous, isn't it? Left lower limb is edematous compared to the right side, and it is red as well, right? The shin, the leg is involved, and the left foot is also involved. Apparently, right leg is normal, right? So it is what? Left-sided lower limb cellulitis. We also might get a different child here. This also looks like cellulitis, right? This also looks like cellulitis. Suppose you are the registrar in the night on-call shift, you are getting both of these children at once. Both of these children at once, right? To whom are you going to attend first? Yeah,
the right side. The right side.
Right side one. So the one with facial cellulitis. Is that correct?
Yes.
Yeah. So is there a particular reason why you want to attend to the left-sided, so this one, than the cellulitic limb child?
Yes, sir, because in the right side, we have to exclude whether it's orbital cellulitis rather than periorbital cellulitis, because orbital cellulitis is an emergency, sir.
Absolutely, absolutely. So this is what? This is something to do with the eye. Not that we are ignoring this child. This child is equally important to us, right? In the UK, whether it is important or not is something. Number two, there is a lot of litigations, right? You can't say, no, there was a periorbital cellulitis child, so I did not have time to look after the other one. Remember, the child with leg cellulitis could also deteriorate. He is also somebody's son or daughter. It's important. Both of these children are important, but this one is more urgently, he would need more urgent treatment. Why is that? This looks cellulitis. This also looks cellulitis. However, this is around the eye. This is around the eye. So when you have cellulitis around the eye, the two possibilities are either it is orbital cellulitis or periorbital cellulitis, right? If you see this child in Viva video station, right? You are not going to get this kind of acute children in as real patients. They would need treatment. They are not going to come to the exam, right? If you see this child in video station, examiner will ask, what is the next step of your examination? What do you want to examine next? Yes, if that is the question, what is your answer?
So to examine the eyes and see whether the movement of the eyeball and to see the basically to examine the eyes to see whether there's
you examine the eye. What do you ask? You show your index finger and ask child to follow, right? Ask child to follow and see if child has normal eye movements, right? If the child is having normal eye movements, yet having cellulitis, we are not very worried because the eye movements are fine. If the eye movements are not fine, the cellulitis has gone into the orbital area or eye tissue as well, right? If you have abnormal eye movements and this kind of cellulitis, that is known as orbital cellulitis. If the eye movements are normal and also having cellulitis, that is called periorbital cellulitis, right? So basically what you do, you check eye movements. If the eye movements are normal, it is periorbital, which is not very urgent. If eye movements are not normal, then it is orbital, then that will need urgent treatment. Right. Now suppose you have examined this child. Eye movements are not there. What will you do now? What will you do now? You are in a district general hospital in Kent, UK. What will you do now?
So then ideally insert a cannula, take the investigations, count CRP culture, and to start prophylactic antibiotics and also to do an urgent ophthalmology referral, sir, for in case to get another opinion. So.
Absolutely. Yes. So what you do is whether it is periorbital cellulitis or orbital cellulitis, it is cellulitis. Therefore, that needs antibiotic treatment, right? That needs antibiotic treatment. So what you would do is, as you very correctly told, you will put a cannula and take bloods for full blood count, CRP, and culture. Full blood count, CRP, and culture, and you start antibiotics. You start antibiotics. What antibiotic are you going to start?
So third generation cephalosporin, like ceftriaxone, maybe.
Yes, you might start third generation cephalosporin like ceftriaxone, but in the exam, right? In the exam, better answer would be, right? Better answer would be, you would say, this child is having orbital cellulitis, which is an emergency. I would put a cannula and take blood and start antibiotics as per local trust guidelines. Local trust guidelines. Every hospital will have their antibiotic policy. So as per that policy, you will start antibiotic. If I don't have such policy in my hospital, I might take senior opinion. I will call my on-call consultant and ask what the best antibiotic would be. If that is not the case, I would prefer to start drugs like third generation cephalosporin. Even coamoxiclav would be sufficient provided I am giving the proper dose. Right? So that is the kind of answer the examiners would expect. Like you would say, you would show that you know the subject. Plus, you would also show that you are a safe doctor. Safe doctor, right? I'm not acting as the superhero. I'm a safe doctor. I would refer to trust guideline, right? I have worked in different hospitals in the UK. Each hospital has their own policy, right? Own policy. Suppose something goes wrong, then the first thing that they would ask is, why did you start this antibiotic? When guideline says the other antibiotic to start, guideline is to start antibiotic A, you have started antibiotic B. Why? Right? Probably you have started that for the good faith of patients management, but you have violated trust guideline. That is not very good for you. If you go to GMC, there won't be any protection. Right? So that is something very important. So in the theory exam, there is nothing called trust guideline in that case. Then you might start things like cellulitis is caused by streptococci or staphylococci. So you might start things like coamoxiclav, or in very severe cases, you can start things like third generation cephalosporin, as he very correctly told, things like ceftriaxone, ceftriaxone. Are you going to start these antibiotics orally or intravenously? Intravenous, right? This is a very severe condition. You don't give oral. Penetration might not be that good, right? Then what do you do? Then what do you do? Say this is orbital cellulitis. You would straight away go for a CT, right? CT brain and orbit, right? Orbit is needed. Plus, we don't know to what extent the brain is involved. So it's important to get that also sorted. Sometimes ophthalmologists will say, no, don't do CT, right? Get a MRI straight away. If that is the case, you would do a MRI, right? That all depends on at what time the patient is coming, what kind of hospital you are working, and what is the availability of these investigations at the point when you manage this patient, right? So it could be CT. The basic one is CT. If not, better thing would be MRI, right? Do you also inform any other person? You have already informed your consultant. You have also informed ophthalmologist. Do you want to inform anybody else? Anyone? Anyone else? Yes. Now this orbital cellulitis, that area is very dangerous. You might also get the infection into sinuses. In that case, ENT surgeon will be very useful. So you would inform ENT surgeon as well. So they will be available. ENT registrar should be informed and say that we have this kind of patient. Right. And then you would keep them in the hospital until we are happy about his or her progress, right? So this is what you do. Suppose next day, child got better, and you see cellulitis is also getting better. Still, the CRP infection markers are high, but he is eating and drinking. Periorbital cellulitis is not that angry looking better, right? Now what will you do? Now what will you do? It looks better, but not normal. What can you do now? Child is eating, drinking, watching television. So what can you do now? This is the second day of treatment. Yesterday night they admitted. This is today evening. Yeah. What can you do now? What do we do in the UK? Right? Most of the countries, developing countries, because the community health sector is not very well developed, they would keep these children for 7 days, 10 days until the antibiotic course is completely finished. But in the UK, because they have good, well-built community pediatric system, right? What we do is we discharge them. We don't discharge. We say something called ambulate. Ambulate the patient, right? You keep the cannula. While having the cannula on the hand, you send the child home. You send the child home. On what? Ceftriaxone. What is ceftriaxone? It's a third generation cephalosporin. It can be given daily, every 24 hours. Say you have given ceftriaxone at 10 a.m. today, you would ask patient and parents to come back tomorrow 10 a.m. Tomorrow 10 a.m. they would come. You will review the child. As long as he looks better, you give the next dose of antibiotic and send them home again until the cultures are back, right? Say the cultures came back, they are negative, you are happy about his progress, and then you can stop antibiotics. Sometimes, depending on the CRP response, suppose it was 200 earlier, now it has dropped down to 100, right? Then you might think, okay, the child is looking better, ophthalmologist is happy, ENT surgeon is happy, our consultant is happy. You might think after completion of say 5 days, you might change antibiotic to oral and send them home. Oral and send them home. And when you send them home, you do something called what? Safety netting. What do you mean by safety netting? You give some advices as to when to come back urgently. You would say, while on antibiotic, if your child starts to have high spiking fever, if the eye redness gets worse, if your child starts to have double vision or anything like that, please come back immediately. Right? Please come back immediately, and you write it down clearly on your system, documentation system. Then the child is safe, you are also safe. That concept is called what? Safety netting. These concepts are very important to remember. These words are very important to remember. When you say those, right, consultants will understand, okay, this candidate knows about our system. That will be a big plus, right? That will be a big plus. So that is something about cellulitis at the very beginning. Now, few things you know very well. Cellulitis is characterized by infection and inflammation of loose connective tissue. Loose connective tissue. It would involve the dermis, right? And relative sparing of the epidermis. So it's more of an infection of the dermis, right? Then there will be a skin break due to trauma, surgery, right? That is when cellulitis would start, right? Most of the children with normal immunity, cellulitis would not go very long. That will settle. However, if the child is having lymphatic problems, diabetes, immunosuppression, right? In that case, it might not control the way that you wanted, right? Then, in theory, you might get this question: what organisms can cause cellulitis? It could be Staphylococcus aureus or Streptococcus pyogenes. Both of them are gram positive, right? Both of them are gram positive, right? Again, the presentation, how do they manifest? There will be edema, warmth, erythema, and tenderness. The typical signs of inflammation will be there, right? And then they also can have fever, chills and dry ghost. They could be malaise, right? So the diagnosis is like largely clinical. However, you can do selective investigations like we did, right? You can go for CRP, full blood count, blood culture, right? So those are the investigations that we would do, right? If the child looks very well, you might go for oral antibiotics, right? As long as child is otherwise well and then there is no nasty area involved like periorbital area or anything, right? Simple cellulitis where the child looks otherwise very well, you can start oral antibiotic as an outpatient, right? As an outpatient. One of the antibiotics that we commonly use here is cloxacillin, right? You can use cloxacillin, flucloxacillin, those can be given. Even cephalexin is okay. Again, there is suspicion of MRSA. So this is something that we learned today. If you are suspecting MRSA and cellulitis, clindamycin would be a good choice, right? Clindamycin would be a good choice. And if the child is acutely unwell and he is not taking anything orally, is that unwell, in that case, you might give intravenous antibiotics, right? Intravenous antibiotics. What are the examples? You can give intravenous flucloxacillin, intravenous amoxicillin, very bad infections, intravenous ceftriaxone, all those can be given. What is the advantage about ceftriaxone? If that is asked by the examiner, ceftriaxone is given daily, right? Every 24 hours. So whenever a child is well, you can ambulate him, right? Ambulate rather than keeping him, right? If you give flucloxacillin, which is given 6 hourly, you can't ask child to go home and come in 6 hours. By the time they go home, 2 hours are gone. Another 2 hours will be taken to come back, right? So then no point of going, right? Whereas ceftriaxone, good 24 hours, they will feel better. That will be good for NHS as well, right? You can give that bed, you can give that room to a different patient, right? There won't be any cost for patient care, food, anything, right? So that would be a better option if you think that patient can be ambulated, right? So that's about cellulitis. I think you understood cellulitis, we all know, but the management in the UK is slightly different when it comes to socio-economical status and all, right? So we need to know that uh, system very well, right? Right. This is our second child or third child coming to the clinic. We can remember the first one. Who is the first one? First one was impetigo. Second one was cellulitis, including periorbital cellulitis. And this is the third one. This is the third one. Right. So what do you see in this child? Right. You see the diagnosis anyway, right? So, however, if you did not see a diagnosis, if you saw this child only, how will you describe? Does this child look well or ill? Yeah, he looks unwell, isn't it? This child looks unwell and he has got multiple lesions, mainly on the face, right? And there is separation of the epidermis, and you see the skin is peeling off, right? Skin is peeling off. So if you see this, is very likely staphylococcal folded skin syndrome or SSSS, right? So this could come in theory and science paper. Theory and science paper. They will test the basic knowledge. They might ask what toxin is involved, what antigen is involved, what layer of the skin is involved, that kind of question, theory and science, right? And then applied knowledge paper, which is fairly more clinical, they might ask, what is the management? What investigation would you do like a proper doctor, right? And then in clinical scenarios or in MRCPCH clinicals, they might give this as a video station, right? Child will be moving around. You might see a temperature chart next to the child. You might, the cameraman might also show a cannula, so that kind of picture, right? Then they would ask, what is the likely diagnosis? So this is staphylococcal scalded skin syndrome, right? And then they can ask a couple of questions. So this is mainly caused by staphylococci, right? Mainly caused by staphylococci, and the spread is hematogenous, right? Spread is hematogenous. So that is something that we need to know. Clinical manifestations. So they might ask, what other clinical features would you look for? Tell me two more clinical features that you would expect, right? When they ask two more clinical features, something, so try to be specific, right? So fever is fairly non-specific, right? Fairly non-specific. That might not bring us any marks. So malaise, fever, irritability, and the skin will be very tender, right? And there will be diffused erythema, right? And then there could be inflamed conjunctiva, right? Inflamed. So there could be red eyes, right? Red eyes if this child doesn't show red eye prominently, but that is something which is possible. And then if you give a gentle pressure on the skin, what do you see? Skin will peel off, right? Epidermis will peel off. Now that is called Nikolsky sign. Nikolsky sign. So what is Nikolsky sign? Epidermis may separate in response to gentle shear force. Now that is called Nikolsky sign, right? So that is something that we need to know. When you give a gentle pressure, gentle rub, you can peel off the skin. That is called Nikolsky sign. So that is something that we need to know. Why are we worried? This per se is dangerous. This is like a burn, right? And this also can lead to secondary infections, sepsis, fluid imbalance, electrolyte imbalance. Right. Now, this child, right? This child, if he comes to you in the casualty night, right? Casualty night or your on call night, he comes to you, right? Would you send this child home after giving antibiotics, or would you rather keep him in the hospital overnight at least? You would keep. You would keep. Why is that? This is like a burn. Just giving antibiotics might not be enough, right? They might have other problems, like they might not like to eat or drink. There may be associated pain in the mouth. So the child will be dehydrated like in next couple of days, or he is already dehydrated, or they might develop some sepsis, right? Some infections are possible. And then electrolyte imbalance could be possible, right? Like we did before, you would put a cannula and start antibiotics, right? We will see what antibiotics start. But when you put the cannula, you would take full blood count, CRP, and blood culture. Would you also take any other bloods? Yes, I would say you would need to take some other bloods, especially for renal function. Renal function. You would take bloods for serum creatinine levels, serum urea levels, serum electrolyte levels. If this was going on for a long time, because the skin is breached, right, this can cause loss of protein percutaneously. That can cause low protein as well. So it's a good idea to check the protein level as well, right? So those are the few things that you would do as initial investigation, right? Then what do? You, as the registrar, you need to make a plan. You need to make a plan. Remember, I think you already know, once you pass MRCPCH, theory and clinicals, right? As long as you are comfortable, you can work as a registrar, right? Registrar, or we'll put it as middle grade doctor. Middle grade doctor, not a very junior doctor, but a middle grade doctor. When you are the middle grade doctor, you have to make management plans, right? You have to make management plan. It is not just manual work, the brain work, right? So management plan, say, either you can call your consultant every time and say, now I have got this kind of patient, I'm going to send you a photo through WhatsApp, tell me the management. Now you can't do it forever, isn't it? Right? Then he will say, okay, why are you working as a middle grade doctor? Why don't you work as a resident or senior house officer, right? So that is not the idea, isn't it? So now we need to make a rational management plan. Now in video station, this patient may be given and asked, write down 4 management options or tell me 4 management principles. So what are the 4 management principles? Now, starting antibiotics is number 1, right? We need to start antibiotics. then you need to start fluids, right? If the child is not eating, drinking, you will have to start fluids, right? And we need to make sure that he is getting a good diet, especially these children are at a risk of getting protein malnutrition. So you would have to give a proper diet. Proper diet. Can you give proper diet through cannula? Can you? Proper diets through cannula? You can give saline. You can give dextrose. But they are not proper diets, isn't it? So what can you give? What are the options? How will you give better nutrition if the child is not eating, drinking? Yeah, few options are either you can put a nasogastric tube and give tube feeding, right? Nasogastric tube and tube feeding. Or if you think that this is going to go for a long time, weeks and all, then what you can do is you can put a central venous line, not a peripheral one, central venous line into a large vein, say femoral, you name, right, jugular, and then you can give parenteral nutrition, right? Parenteral nutrition, right? If this child is getting malnourished, what options are available? If that is the question, two options are either you can feed through NG, nasogastric, or you can give parenteral feeds, right? So those are the options. Now, when you give parenteral feeds or NG feed, nasogastric feed, who decides what the best food or what the best uh, package of meal that this child should have? Who decides in general? Is that the middle grade registrar or the consultant? Who? Generally, it's the dietitian. Dietitian. So every hospital has got a pediatric dietitian, at least most of the hospital. If your hospital doesn't have, there will be a tertiary hospital looking after your hospital. You need to call them and say, now look, we have this child. We are planning to give like parenteral nutrition or nasogastric feeds. What do you think as the best um, food to give? Then they will give a diet plan, right? Then they will give a diet plan rather than we giving blindly. We need to get the advice from dietitian because they are trained for this function only, right? They are trained for this diet planning only. That is their specialty. Right? We don't call them for any other reason. So diet, because they are the experts. So we would say I would liaise with dietitian and make sure that child is not getting malnourished, right? So those will be definitely there in marking scheme if they are talking about the diet. So fluids, right? IV fluids, if you think the child is acutely dehydrated, and then nasogastric feeds or parenteral nutrition, depending on the child's condition, right? And then antibiotics. And then if there's any electrolyte imbalance, that should be corrected as well, right? Electrolyte imbalance, that should be corrected. So systemic therapy, right? You can give oral very rarely if it is just local, but commonly what we give is intravenous antibiotics, right? So we can give anti-staphylococcal antibiotics, right? Again, you can go for things like flucloxacillin, right? Vancomycin. Don't worry about the antibiotic name. You would always say, I would refer to trust guideline, or I would talk to my consultant or microbiologist in my hospital, right? So those are the few things. However, in general, these are the possible options. So that is the kind of knowledge that they would expect from a registrar, right? And then we also can go for clindamycin, right? Skin moisturing is needed. Sometimes an emollient would be helpful, right? An emollient would be helpful to keep the skin not getting dry, right? And what else? Of course, they will need fluid resuscitation and proper diet, right? Proper diet. So this could be a spot question, spot video station. It could be a MCQ or it could be uh, like clinical scenario, right? Okay, right. Okay. So what do you think this as? This 9-month-old male infant presented with 3 days history of fever, rhinorrhea, and a rash. His mother has brought him to GP, who prescribed erythromycin and antipyretics. Child didn't improve. The rash got worsened, extend into his face, rest of the body, in particular axillae and groin. Right? Axillae and groin. What is the most likely diagnosis? Most likely diagnosis. Where did I get this question? This is from MRCPCH website. They have given a couple of questions for candidates to get an idea how do they give questions, right? So this is one of those questions. If you go to MRCPCH website, you can see these questions anyway, right? Okay, so what do you think as the diagnosis? So this is the picture, and is that atopic dermatitis, herpes simplex, impetigo, staphylococcal scalded skin syndrome, or is that Stevens-Johnson syndrome?
It seems like Stevens-Johnson syndrome with the history that's there.
Yeah, this could be Stevens-Johnson syndrome. Somebody can argue that this could be Stevens-Johnson syndrome. What is the other possibility? Other possibility? Could that be staphylococcal scalded skin syndrome as well? You can see the skin is peeling off, right? Skin is peeling off, and there is this rash as well, right? So in Stevens-Johnson syndrome, there will be more of mucosal involvement, right? So mouth will be red. There could be red eyes. So we don't see them particularly in this child, right? Particularly in this child. Therefore, the best answer that they have taken in this scenario is staphylococcal scalded skin syndrome, right? And when they are on antibiotics, right? When they are on antibiotics, Stevens-Johnson syndrome is something that we need to consider because this could be a side effect of antibiotic. However, erythromycin is not something which can commonly cause this, right? He has been on erythromycin and antipyretic, so those might not cause Stevens-Johnson commonly, right? So the best answer out of 5 here would be staphylococcal scalded skin syndrome, and this is not impetigo. Impetigo usually doesn't cause this kind of peeling, right? There may have been initial impetigo here, right? But not the full picture, right? And atopic dermatitis, we will go through those pictures. This is not the appearance of atopic dermatitis. And herpes simplex, there will be blisters, right? There will be blisters here, no blisters, but this is just peeling off of the skin,